So my talk today is on solid organ biopsy, so quite a basic topic in interventional radiology. I'm sure you all know a lot about it already, but I think it's always good to have a little refresher and to kind of organize your thoughts on the basics to have firm grounding in the basics. Yeah, so I'm going to start talking about some of the like patient preparation and scheduling things to consider when you plan organ biopsies. Then also some clinical aspects, and then we're gonna talk about some of the technical aspects, imaging modalities that you can use, and finally do a little bit on the individual organs and yeah, all the possible complications and what size of needles you want to use and all that. So let's start with the pre-procedure planning. So usually people will, referring physicians will ask you to do a biopsy on a lesion. There's usually some type of imaging done, or maybe it's a lesion that is clinically apparent. It's a superficial lesion, then maybe you don't have imaging. So what do you need to know? Well, biopsy should always guide therapy. So the most important thing to ask yourself is always, what is the indication for the biopsy? If you're not clear on the indication, if the indication is not clear from the clinical picture or the imaging or the whatever the referrer has given you an information, then you should try and discuss with the referring physician and find out what the indication for the biopsy is. There's no point in doing a biopsy if just because you're interested in what something might be, or just to confirm a diagnosis that is actually confirmed already. Especially this goes especially for biopsies that are more risky, because you don't want to take a risk if there's not much to be gained. So that's a very important point. Sometimes difficult to get a hold of referring physicians and to get all this information. So practically that can be really annoying. Then of course you need to know what medium you're gonna send your biopsy in. So what might it be? Usually you'll use formalin for core biopsies, and if the patient is consenting to the biopsy, because if they don't want something, then they don't need to have it. Then you usually, if you have imaging available, you're gonna already plan your biopsy even without the patient present. You try and find the safest route. So if there's multiple lesions, you can select a convenient lesion. What's a convenient lesion? A convenient lesion is one that is accessible, but also one that is large enough to biopsy, and that has viable tissue. So if you have a contrast imaging, like contrast CT or contrast MRI, if something takes up contrast, then you can be sure that that is viable tissue. You don't want to just end up with a biopsy of necrosis, because pathology is not going to be able to tell you about that. And then figure out what equipment do you need. Do you have this equipment available, or are you going to get it from somewhere, or is the patient going to have to buy it? Then you can already think about what imaging modality you're going to use. Mostly ultrasound CT. We're going to talk about that later. And think about what likely complications you're going to have, and if the risk is if that's a tolerable risk. So sometimes you may end up with a biopsy request that actually does make sense, but you'll have to say that it's not feasible to do that biopsy because it's too risky. When you know what complication you have, then also make sure you have the material available to treat the complication. Like, for example, have a chest drain available whenever you do a chest biopsy or even a liver biopsy. We're going to be close to the pleura. Then you schedule the patient. So usually biopsies will be day cases. Most biopsies are not that complicated, unless if you expect the biopsy to be very difficult or high risk. The high risk can be because the lesion itself is high risk or the organ is high risk, for example, high risk bleeding. Or there can be patient-related the things like, for example, if you do a lung biopsy, someone who only has a single lung or has a chronic lung disease, then you may want to opt for a inpatient procedure. Try to do morning time and get day cases so that you can keep the patient for observation and no one has to do overtime. Also, the patient should be fasting for 4 to 6 hours in case of complications. That's also better for the patient to have the procedure in the morning. Then you need to figure out beforehand if you need anesthesia or not, because if you need anesthesia, then you're going to have to tell them about it. Consider anesthesia, especially in children and adolescents. Although often you'll be able to do your own conscious sedation depending on how much, like your own experience and your local hospital guidelines. And also elderly patients are often less compliant. You can also consider anesthesia in those. Also painful locations, like for example bone biopsies, at least have a good plan for pain therapy, pain management. Then you should think about hemostasis. So that's mostly what type of labs are you going to ask the patient to bring, and what type of lab, like what values are going to be okay for you, acceptable, and what needs to be corrected. So there's different guidelines. For example, there's the CSA standards of practice. Then there's also the consensus guidelines of the Society of Interventional Radiology. Maybe you also have local or national guidelines. Whatever guidelines you use, make sure they make sense for your local setting. This is an example from the CSA guidelines. They usually, most of the guidelines are quite similar. They usually divide the procedures up in low risk or moderate to high risk procedures. And for biopsies, most biopsies fall into the moderate to high risk category. Renal biopsies are considered high risk. Lung, liver, deep intra-abdominal, thoracic, and retroperitoneal biopsies are considered moderate risk. Low risk are superficial interventions like breast, lymph nodes, thyroid. So for moderate high risk of bleeding, which will be most of your biopsies, you want an HB that's over 8, a platelet count is over 50, and an INR of less than 1.5 if the patient is on a vitamin K antagonist. If the patient is not on a vitamin K antagonist, then it kind of depends on what the reason is for the INR to be suboptimal, and if you have ways to correct it or not. So that's going to be your decision on a case-to-case basis. Also, how important is that biopsy really? You're just going to have to weigh the risk and benefit. So risk of bleeding, you have a little like looser guidelines. So the HB should be over 7, platelet count over 20, and INR less than 2.0. Periprocedural, when the patient is there. So this is only like the clinical aspect of it. So you should monitor vitals depending on your risk, on the risk of the procedure, and on whether you're using fentanyl or midazolam. If you have anesthesia, then usually the anesthesia team is going to take care of your monitoring. But if not, then figure out if you need a ECG, if you need like if you have a simple biopsy, then maybe just a pulse ox is going to be enough. That depends on the risk and on what patient you have. Consider what complications you might have already said that you might have, and make sure you have the material available in case. Always prep a wide area. So always prep more than you think you need, because you might, the track that you planned may turn out to be not perfect, and you may want to change it, or you may want to use a different lesion. For example, if you do a liver biopsy, you might find that it's maybe not the best. You haven't picked the best lesion, and then you have the option to use another lesion. And also, when you do an ultrasound guided biopsy, make sure that you have enough space for your ultrasound probe, because if you put your ultrasound probe on the drapes, then obviously you're not going to see much. Then figure out if you need venous access. So that's mostly also same as with the monitoring, a question of risk. Usually venous access is never a bad idea. And if you do sedation or use opioids for pain management, then have your reversal agents available. You should always do a team timeout at least. CSA suggests a complete checklist also for procedure planning and for sign out. Usually, if you have good procedures in place that make sure that you don't forget things, like in the planning phase or after the procedure, then you don't need to have like this checklist. I think it just make sure that you never forget. But team timeout should be the minimum, so you should always have a team timeout before you start the procedure. Small word on pediatrics. Mostly you try to use ultrasound on pediatrics. Ultrasound also works very well with children because they don't have much subcutaneous fat tissue, and their overall body diameter is quite small. So visualization in ultrasound is superb in children. And also you save the radiation exposure that comes with a CT. Also, if the patient moves a little in ultrasound, that's not such a big deal, because you have real-time imaging, and in CT that may be a problem. Sedation in children is almost always necessary, even in adolescents, even if you think they may be able to tolerate the procedure. Often when you do that, the procedure does end up to be very painful, or at least very stressful for an adolescent, and that way you can kind of traumatize them for the future. So you kind of make your own work and other doctors' work much harder if you give them that one bad experience, because then in the future even minor procedures may be a big problem for them, and they won't be compliant. So it's better to sedate children a little more, like to just not, you don't need deep sedation, but just sedate them so that they're relaxed, and make sure that pain management is adequate. And that way, the next time they're going to come in, and they're going to still trust you or trust other doctors. So that's usually worth it. And also they usually tolerate sedation quite well, because most children don't have lots of comorbidities. They don't have any pulmonary issues or anything. When you do sedate them, then obviously you should have a pediatric airway management, like you should have the material available for pediatrics and not just for adults. Then a calm and quiet environment goes a long way in children. When you reassure them, then you really do reduce the need for sedation, because the children will be led by your attitude. And if you have a positive attitude, and if you make the whole thing light and not stressful for them, then they're going to relax, and they're not going to need a lot of pharmaceutical sedation. In babies less than 6 months, you can consider milk sedation. So you basically just make them fast for 4 hours, and then breastfeed. or bottle feed or whatever. And then you feed them, and then after that, they usually sleep. And then if you do proper good local anesthesia, then they don't really necessarily wake up. For equipment, you try to use material appropriate for patient size, of course. So you use smaller needles than you would in an adult, but also you need to keep in mind that the histological, like the needs of pathology to make a diagnosis are pretty much the same as for tissue taken from an adult. The cells aren't any different, they're not any different, not a different size, and so you usually don't go anything smaller than 20 gauge. And even like if you can use an 18 gauge safely, then you can also use that and make the pathologist's life a little easier. And yeah, for infants, you can use linear ultrasound probes because of the small body diameter. Okay, so now to the more technical aspects. So you choose your imaging modality. Those are your main two imaging modalities that you are going to use for biopsies, ultrasound and CT. Sometimes you can also use fluoroscopy. Most of the time you'll maybe use fluoroscopy in addition to ultrasound and not on its own. But yeah, sometimes there may be maybe indication things that, for example, you could do like a jugular liver biopsy if it's not a lesion, but if you just want to do a non-targeted liver biopsy, then you could just use fluoroscopic guidance, and you wouldn't even need to use ultrasound. But those are rare cases. When you choose the imaging modality, you have to, obviously, the modality needs to be able to demonstrate the lesion. You need to be able to see adjacent structures, vital adjacent structures, and consider that some lesions require IV contrast. Sometimes the combination of more than one is better than just one modality. For ultrasound, I guess most biopsies are done ultrasound guided. The main advantage is that you will have real-time imaging. And so when, for example, for a liver biopsy, the patient is breathing, you can actually see where the pleura is, you can actually see your lesion moving, and you can adjust it accordingly. And you have multiplanar monitoring, so you can orient your probe in whatever direction is most convenient for you. And you have no radiation on the patient, and also no radiation for yourself. Try to be aware of your ultrasound physics, of the basics when you do a biopsy, because that's going to make your life easier. So think which way the sound waves go in a curved probe and in a linear probe. So in a linear probe is quite easy because they're all parallel. And the visibility of a needle, because that needle is metal, right? So it has a reflective surface. So basically just reflects the sound waves, but it's only going to reflect the sound waves back to the probe if it is more or less perpendicular to the probe. It doesn't have to be 100% perpendicular. That's not even possible most of the time. But if the tract is too steep, then it's just going to reflect the sound waves someplace else and not towards the probe, and you're not going to be able to see it. So for linear probe, you try to go as horizontal as possible, and that way you will be able to see the needle along its entire tract. You achieve that by choosing your entry point a couple of centimeters away from the probe. When you choose your entry point at the edge of the probe, then usually your tract is going to be too steep. Another point is that you usually use linear probes for superficial lesions, like like in this example, a breast lesion. And if you use a steep tract, then you risk injuring deep structures. So like nerves and vessels in the chest wall. But it's also good for visibility to have this horizontal pathway. And for a curved probe, the sound waves fan out. So they go in different directions, wherever, like in different parts of your image. So if your tract is too steep, if you start like too close to your probe, and you choose a very steep tract, then maybe you're even still going to be able to see your needle at the edge of your image, because at that point it's still more perpendicular to the sound waves. But the closer you come to the center of your image, which is usually where you're going to have your lesion, um, the less you're going to be able to see the needle. So you might get in trouble because you maybe just not be able to see your needle tip. So make sure that you always try to go at a, well, let's say, try to have as perpendicular as possible, so as feasible. Sometimes you need to choose a steeper track than you want to, but it's just more difficult. Then for CT, well, great spatial resolution. Air is not a problem, and also the depth of the lesion, the depth of the tissue is not a problem. So you can see all the way into the deep retroperitoneum, but also you can see into the lung, and yeah. Unfortunately, there's obviously radiation for the patient, also for yourself. So for CT, you can use skin markers to choose your entry point. You're going to be able to see the skin markers on the CT image, and then you're going to be able to count out the lines and make sure that your entry point is where you want it to be. Usually you use something like 3 times 1 millimeters or 3 times 3 millimeter slices. Have real-time imaging unless you use CT fluoro. I don't know. I think I've never used CT fluoro. Some people use it for very difficult access routes. I don't really think it's necessary, but it's an option, but it has a very high radiation dose. So usually you go with your 3 slices. And you have to be aware that there's a space in between the slices. So if you see the needle on one slice but not on the other, it does not necessarily mean that the tip of the needle is what you see, but the tip of the needle might be in between the slices. So you should try and visualize the entire needle and not just bits of it, and also look for needle tip artifact to make sure that you actually do see the tip of the needle and that you're not deeper in the tissue than you think you are. Here's an example. So on the left image, we see one bit of the needle, but we see that it's traversing the image plane, because otherwise we'd be able to see the entire needle or no needle at all. So it's traversing the plane, so we don't really know if this is the tip of the needle or if this is just a part of the needle and the tip is outside the imaging plane. In the second image, the operator has corrected the angle of the needle a little bit. And what we can see now is that we see the entire needle, and also that we have the needle tip artifact, which is this black streak on the kidney. And on that image, we can actually be sure that this is the needle tip and that it is deeper than in the other image. And that way we can do a safe biopsy and not overshoot. So how does a core biopsy needle work? This is the standard core biopsy needles. There's lots of different manufacturers. It has an inner stylet that is advanced into the target tissue that can be manual, or there are also automatic versions where you just press a button. And the inner stylet has this little notch, and that notch is where the tissue that comes to lie in this little notch is what's going to be the biopsy. It's going to be the core tissue sample. And then there's a cutting cannula outside of the inner stylet, and that cutting cannula is advanced over that notch, and that way cuts the tissue that's in the notch. And then we withdraw the biopsy needle from the tissue, and we can take the tissue sample out of that notch, and that should be, in the best case, with the tissue architecture intact without crushing anything. There, you can use that with or without a coaxial needle. A coaxial needle is basically just a needle that you advance first. The inner stylet of the coaxial needle has the same diameter as the outer diameter of the biopsy needle. So naturally, if you use a coaxial needle, you're going to make a hole that is a little larger, usually 1 or 2 gauge larger. But you only need to do that one time, and then you can use the coaxial needle, like the tube of the coaxial needle, to advance the biopsy needle several times. So you decide that for yourself if you want to use coaxial needles or not for each patient. I personally use coaxial needles most of the time. I think it's a good trade-off. Like you have a larger hole, but you only have one of them. You don't injure the organ capsule several times. Plus, also it's good for patient comfort because they're not going to feel the advancing through the coaxial needle. But if you advance the biopsy needle by itself one time and again, then every single time that's going to be painful to the patient. There are a few special biopsy needles. Most of them are not used that much, I think. There's a steerable needle that's quite self-explanatory, where you can steer the tip, and so the direction of your biopsy at the tip. There's blunt needles. There are full core needles that basically get a better core that is better preserve the architecture of the tissue better. So if it's very important to have the tissue architecture, not just the cell types, then a full core needle could be beneficial. And then there's vacuum assisted, that's usually used for bone biopsies, because with the usual core biopsy needle, you won't be able to penetrate a sclerotic bone lesion, and you're not going to be able to get out that that tissue sample. So there we use vacuum assisted needles. Position your patient. Well, keep in mind the ergonomics for yourself, because you don't want to hurt your back, and you're doing this all day. So make sure that you're comfortable, but also make sure that your patient is comfortable. The more comfortable the patient is, the less movement you have. Supine position is best for sedation, obviously, because you have best access to the patient and to the airway. Describe beforehand what the patient might be seeing during the procedure, because lots of people will get very scared when they see the 20-centimeter biopsy needle for the first time, and so you explain it to them, explain that not the entire needle is going to go inside their body, and also demonstrate the noise that it makes when the biopsy is taken. That way you can ease anxiety in the patient. Sometimes you can also, if you feel like your patient is very anxious, you can try and shield them from seeing the procedure with drapes and things like that. Some people use ipsilateral decubitors to reduce the movement of the hemidiaphragm, for example, in liver biopsies or in lung biopsies. You choose your route. What's your target? Make sure you know what your target is. Choose your target wisely. Avoid vital structures. Of course, try to pick the shortest route that's feasible. Try to stay in a single compartment. So if you have a retroperitoneal lesion, try not to go transperitoneal, for example. And for small lesions, take the long axis. That way you reduce the injury of the Okay, sorry, that was my internet connection. Can you hear me?
Yes, yes.
How long was I out? I just wait,
About a minute.
about a minute. Okay, that's not too bad. This slide here?
Yes, that was.
Okay, great. Okay, so I was saying try to think about alternatives as well, and if necessary, you can refer your patient to another department. For example, if you think that transbronchial approach is safer or easier, and if that is available in your hospital, then you can refer them for bronchoscopy. And then pick the correct needle size. Of course, think about the indication. Is it a primary diagnosis, or is it molecular analysis, or is it a known primary and you're just trying to confirm if the metastasis is indeed a metastasis of that known primary? So for example, for the liver, you may want to use a larger core needle if the primary is unknown or if you have diffuse liver disease, but 17 to 18 gauge is usually sufficient for a known primary. It's similar for kidney. 16 gauge if diffuse. Smaller is okay for a lesion, but if you go too large, then you significantly increase complication rates, so don't do that. If you can try to rotate your needle when you take the biopsy. Between taking biopsy samples, that will increase your tissue yield. If you have a difficult axis where you think something is that you feel like is a little dangerous, maybe trying to go close to a blood vessel or something like that, then you can use a tandem technique. So you can first introduce a small needle, thin needle that won't do too much damage if you misplace it, like if you place it in the wrong place, and then you place your biopsy needle side to side parallel to that needle. Usually you'd use that technique in CT guided biopsies. You could bend the inner stylet just a little bit if that helps your access, but not too much, otherwise the biopsy gun won't work anymore. If in ultrasound you feel like you can't see, you're not sure if what you're seeing is really your needle, your biopsy needle, then move the stylet within the needle. That can help you. And sometimes it can be helpful to dissect tissue with a small amount of saline or local anesthetic to create some space, or to move other structures out of the way. So now let's talk about some of the organs that you might want to biopsy. This case here, there's a patient with a known colorectal cancer and chemotherapy. And then you have these liver mets. Would you want to biopsy that? Yes or no? Do you think there's an indication to biopsy? Maybe you can just think about it for a second, or even give me a thumbs up or down and assume. Okay, obviously we want to biopsy that. Sorry? You can hear me, yeah?
Yes, we can.
Yes,
Okay,
we
great.
can.
Okay, great. No, I was just because someone said something, so I thought maybe you couldn't hear me. Yeah, so of course we do want to biopsy metastasis, because it might be metastasis of some other primary. If it has if we found new metastases under chemotherapy, it could be a different primary, or it could be the tumor could have mutated and the chemotherapy is clearly not working. So to guide therapy, it makes sense to biopsy that. Other indications for liver biopsy is undetermined liver lesions, of course, that if we don't know what it is, especially if it does look malignant. And then for non-targeted liver biopsies, you can ask about what is the stage of a known parenchymal disease, like liver cirrhosis, like non-alcoholic fatty liver disease, like PBC, or if you have abnormal LFTs of unknown etiology and there's no other way to find out what's wrong, then you can do a liver biopsy, or like hepatic storage disorders. Undetermined liver lesions, well, if you think it looks like a hemangioma, don't biopsy it. So there's also, make sure that you have the proper imaging available, because you don't want to biopsy every undetermined liver lesion, but one that looks malignant, you should biopsy. Then also, if you have an hepatocellular carcinoma that has a typical contrast enhancement for hepatocellular carcinoma in one or two imaging modalities, then according to most guidelines, you do not necessarily need to biopsy that either. But well, check your local guidelines and whatever. Also, clinicians feel comfortable with if they say they don't want to treat without histologic confirmation, then you can also biopsy a HCC, I suppose, but you don't, just keep in mind that it's not always necessary. So if there's ascites present, try to tap the ascites or have it tapped by someone else. You don't wanna go through the ascites, because that increases bleeding risk and infection risk, and just makes your life difficult, because the liver is not gonna stay stationary. Ultrasound guided is usually preferable in the liver. I guess you'll know that. Decide if you want shallow breathing or breath hold. I usually go with shallow breathing. I feel like that works a lot better. Most people are not really able to hold their breath for very long, especially as soon as they are under stress or they feel pain. And so it might work at first, and then as soon as you start actually doing your work, the breath hold is not going to work very well anymore. So shallow breathing is usually the better option. Some people use ipsilateral decubitus, but don't usually do that, to be honest. Always plan the route with intervening normal liver. You should all know that, because that way you decrease the risk of hemorrhage and of peritoneal seeding. And of course, avoid the pleural recess and try to confirm the abscess of a pneumothorax post-intervention. You can usually do that with ultrasound. When you're done, make sure that the pleura still moves up and down with respiration, and that way you can see that there's no pneumothorax. So this patient has macrohematuria. Question, so they want you to biopsy that. Do you want to biopsy it? Just everyone make up their mind for a second. Yeah, we'd rather not biopsy that lesion. It looks very much like a renal cell carcinoma. It is a renal cell carcinoma in almost all cases, and a biopsy has a pretty high risk of bleeding. You can see there's avid contrast enhancement, so the biopsy is risky, and the diagnostic yield is low because you're going to have to do a partial nephrectomy anyway, so you can do it in the first place. Plus, also the differential diagnosis is oncocytoma, but studies have also shown that lots of biopsy-confirmed oncocytomas actually do contain renal cell carcinoma, like bits of renal cell carcinoma, and then end up being renal cell carcinomas, like end up growing and into renal cell carcinomas anyway. So you might even do harm because the pathologist might say it's an oncocytoma, then it's left in place, and then the patient is going to, like the disease is going to progress. So try not to progress to biopsy renal cell carcinomas. Educate your clinicians as well. Discuss with them that why you don't want to biopsy it and why it makes more sense to go straight to a partial nephrectomy. So what are the indications? A focal lesion that is non-characterized on diagnostic imaging. So if you're not sure if it's a renal cell carcinoma or a renal lymphoma, for example, things like that, or even an abscess, maybe. Well, there's scenarios where you don't know what it is, and then you may want to biopsy it. Also, if you need molecular characterization for chemotherapy for a lesion that is known, then that might also make sense if there are no other lesions in like nodal disease or anything that's accessible. And another for a non-targeted biopsy, the indication would be renal failure with an unknown cause or nephropathy. The technique, you try to correct coagulopathy, obviously for every biopsy, but even more so for renal biopsies because the risk of hemorrhage is just higher. Make sure to manage hypertension. According to a study, the bleeding risk is increased up to 10-fold when the blood pressure is over 140/90. And that's a lot of people who have the blood pressure over 140/90. So you can manage hypertension in the short run, with medication, and try to manage that also during the procedure, because the blood pressure might rise with the stress or pain. So make sure you monitor blood pressure and make sure you manage it. Direct the needle at the pulse, never at the hilum, so that if you overshoot, you don't injure the hilum. The inferior pole, for obvious reasons, is usually what is picked because it's easiest. Of course, if you need to biopsy a specific lesion and that is not at the poles, then you can't direct your needle at the poles, but you still make sure to not direct the needle at the hilum, but go diagonally so that you can still overshoot and not do too much damage. And try to avoid to biopsy atrophic kidneys. It's usually no diagnostic yield. The complication risk, like bleeding risk, is definitely increased. Well, unless you really have a lesion on an atrophic kidney that definitely needs a biopsy for management, but that is usually not necessary because if it's atrophic, you might as well do a nephrectomy already. For the spleen, very short, well, usually you don't do. It's very risky and there's usually no necessity. So it's very rarely done. An indication would be an extrasplenic neoplasm and indeterminate splenic region. So basically try to find out if it's a match or not. But that only makes sense when it's necessary for management decisions. So basically, if it would be the only metastasis and it would upstage the tumor, then that might be a reason to do a biopsy. But also try and figure out if you have other ways to find out what it might be. For example, if you have PET-CT available, that could be an option. Or yeah, that could be an option. But or if another imaging modality, if you can do an MRI, maybe you're gonna have more information. And then also lymphoma would be an indication when no other organ is available for biopsy because it's only the spleen, or because all the other everything else is even risky. But other than that, there's not really an indication to biopsy the spleen. For technique, track embolization could decrease your risk of hemorrhage. So for this, I think this is pretty much one of the last slides now. Which slides would you prefer to biopsy this lung lesion on? So usually lungs we would use CT guided. Obviously that doesn't usually work with ultrasound very well. But so there's two slices of the same lesion in the same patient, and which one would you pick? So in this case, they picked number A. And why? Because on B, well, you may not be able to see this on your screen if you're watching on a small screen, but even if you can't see it, then that is where the fissure usually is, right? At that level, the fissure is going to come down. You're going to have some inferior lobe here and superior lobe here. And so if we biopsy through here, then we're going to go across the fissure, and that definitely increases the risk of a pneumothorax. So even if the lesion is larger on B, so it would be very easy to hit that with a biopsy gun, but that is riskier. So we would pick A. So indications for thoracic biopsies, pulmonary lesions, if it's inaccessible to bronchoscopy or less accessible to bronchoscopy, or if bronchoscopy is just unavailable. And for mediastinal or pleural masses, contraindication specific to chest biopsies or to lung biopsies actually is if there's poor respiratory function or rehab. So you should be sure that the patient is at least going to be able to survive with a pneumothorax if you put a chest tube in. If you think if they're already if they're already struggling with their breathing and the oxygen saturation, and even when you do supplement oxygen, then you should be careful doing those biopsies. Well, technique, obviously, like I said, usually CT guided. You can use a radiopack grid. You usually use a radiopack grid. That's an example here of a grid that you might use. You can then see those little dots on your CT image and make sure you pick the correct entry point. Try to avoid fissures. Like I said, increases the risk of pneumothorax. Keep the patients for observation for a little while, depending also on the patient, on how stable they are, but also on your local, how long you usually keep them. And consider chest X-ray to exclude a relevant pneumothorax, for example, at 4 hours. Not every institution does that. We do that. I think it's not a bad idea. Then bone lesions could be lytic or sclerotic. Any focal lesion is usually an indication unless you really know what it is. Also suspected plasmacytoma as a or less focal lesion, more generalized. Plasmacytoma can also be diagnosed with a bone biopsy. Technique for sclerotic lesions, usually you use a drill. It's at least helpful and sometimes even necessary to get to the lesion. And then, for example, you can use a 10 gauge coaxial and a 13 gauge vacuum assisted biopsy needle. And you always try to do at least 2 passes, not just one, even if it's difficult. For lytic lesions, you just do a normal core biopsy, would use a 16 gauge, and you can consider if it's feasible to do ultrasound guided. Sometimes that works, and ultrasound is usually more available than CT. Make sure you have a plan for pain management because bone biopsies are painful. So yeah, consider sedation and opioids, but it depends on availability. But at least try to think about it beforehand. And then lastly, breast and soft tissue. Indications are BI-RADS 4 or 5 lesions. For outside the breast, you have focal soft tissue lesions and nodal disease. For technique, you usually use 14 to, that's supposed to say 16 gauge for breast, and for other superficial lesions, you just get a larger core. It's better for molecular analysis, and for lesions that are that superficial, the risk is just quite low. For deep lesions, 17 or 18 gauge. For breast lesions, especially if they're small or if they're partially cystic, consider placing a clip because the lesion might just vanish in the hematoma that you create with the biopsy, and then you're in trouble if it's malignant. That's it. Thank you very much. And are there any questions? Can you guys still hear me?
Yes.
Thank you,
Clear.
Miriam.
Thanks so much.
Sam posted a question on the chat. He was asking milk sedation. It was not very clear. Are
Sorry?
drugs, milk, or breastfeeding alone is used as a sedation method?
Sorry, say again. Milk sedation?
There's a question in the chat from Sam. He asked, milk sedation was not very clear. Are drugs put in milk or breastfeeding alone is used as a sedation method?
No, breastfeeding or milk is used alone as a sedation method. So there are no drugs put in it, although you can combine it with drugs, obviously. But milk sedation itself is basically just that you let the baby fast for 4 hours. So usually the babies that age, they feed in intervals of less than 4 hours. So you let them fast for 4 hours. That way the baby gets super angry and very upset, and then you feed them. And after they're fed, when their belly is full, they become very tired. It's just a physiological response, and they just sleep. And for things that are not very painful, that is usually enough. You have like maybe an hour where they will just sleep. Obviously, if it's gonna be if you expect pain, like you can also use that in combination with drugs, but you will just need a lot less than as well. So it always makes sense up to 6 months of age. It's very impressive in some babies how well that works.
I'm
Thank you
pretty
for the
sure
clarification.
that was invented in Germany using this technique.
You
In
think
the US,
so?
people would be like, "Oh, you're torturing the baby."
You're just starving the
No,
baby.
but it makes sense. It makes a lot of sense.
I mean, it is something that you really have to explain very well to the caregiver, because it is difficult to make a baby just wait for food for an extended period of time, because they get really upset. And obviously it's an instinct to feed that baby, and you need to explain it, but it works very well. Yeah.
Sweden is even worse. My mom put me to sleep outside in the snow in the winters to toughen me up. So these are just European methods.
I think babies sleep very well in the cold.
Yeah, yeah. I know. Didn't hurt me. All right, I'm gonna have to log off. Thank you so much, Miriam.
Yeah, great. See you soon.
Thank you so